everyone. Welcome to Women Who Win, a global media platform to empower women across the globe. In this video series, we share stories and information that are of utmost importance to women across the globe. I'm your host, Dr. Deepa Javeri, and I'm a podiatrist. I practice at Boston Medical Center as well as Beth Israel Lahey Hospital here in Boston. It is my true honor to introduce you to our guest today, a fellow Bostonian. We have Dr. Fatima Cody Stanford. And fair warning, she has a long list of accomplishments, some of which I will mention in my introduction. Dr. Stanford is one of the first fellowship-trained obesity medicine physician scientists and educators. She specializes in the care of adults, adolescents, as well as children in overweight and obesity. After completing her fellowship in obesity medicine and nutrition at Mass General Hospital and Harvard Medical School, and a Zuckerman Fellowship at the Harvard Kennedy School of Government, she joined the faculty, at the Mass General Hospital and the Harvard Medical School, where she provides clinical care, supervises trainees, and conducts research on obesity, health policy, and health disparities to enhance our knowledge and quality of patient care in the United States, as well as throughout the world. It is truly a pleasure to welcome you and talk to you today, Dr. Stanford.
Thanks for having me. It's a delight to be here.
Thank you. So I would like to begin with just some basic things that concern all women in general. And I know you've done a lot of research, and based on your research, what is the impact that our environment and things around us and the role that our bodies and brain plays in the complex process of weight regulation?
Oh, so I'm so glad you started with that. I know for those who are listening, wow, that's a complex question. And so I kind of want to bring it down, simplify it for people so that they just understand kind of what we're talking about. So when we're talking about weight and weight regulation or obesity as a disease, what a lot of people don't know is that this is a disease that's beyond this idea of willpower, that it's not something you just choose to have and something that you just do based upon your environmental exposures. So the brain is actually the organ that regulates our weight. And it's getting signals from different parts of our body. It gets signals from our fat tissue, our small intestine, our large intestine, our pancreas, our stomach, and it tells our body how much to eat and how much to store. Now, the brain obviously functions in the environment that we exist in. So obviously there are influences in our environment that can choose us to maybe want to eat more in certain situations, but a lot of that's driven by our biology. So for example, one person might walk past a chocolate store and be like, wow, there's a chocolate store, I need to go inside. Whereas I walk past the chocolate store and not even notice it's there. I'm not a chocolate enthusiast. I know, not like a normal thing, but
you're
that's
lucky.
just one of the things, right? So it shows you that our bodies are influenced very differently. What our bodies desire, how we operate in the environment differs drastically. And so what my job is when I'm working, for example, with patients, with women, for example, is to find out how much of what their weight regulation issues are due to maybe environmental triggers, or maybe due to other things. Like one of the key issues that really influence weight in women are hormonal changes at different parts of our life. Like when we first get our menstrual cycle as adolescents, we see weight shifts that happen there that are just largely determined by those hormonal changes. If we get pregnant, whether or not we, have a carry to full term, those hormonal changes associated with pregnancy can cause major weight shifts. And then the one that none of us can avoid, which is menopause, that change where we have a drop in estrogen causes major weight shifts, where we go from having a gynoid, which means a female-like pattern of weight, which means we carry our weight in our hip, buttock, and thigh region, to having what we consider to be an android, not the phone, you guys, but a male-like distribution of weight, which is in the midsection. So weight carried in that central region, right in the stomach area. So there's so many different factors that play a role in how the body regulates weight. And it's part of what makes my job exciting and challenging all at the same time, because each individual, my goal is to try to figure out what things can I influence to get someone to a happier, healthier weight for them.
Wow, I love how you simplify that for everyone. And speaking of hormones, and I love how you broke down the aging process, that actually leads right into my next question, which was, For years we heard how metabolism changes with age, and then we heard metabolism is not as much affected by age. What is the relationship between metabolism and age?
I think that I think the issue was that when we thought about metabolism in the past, we thought that that's what regulated our weight, right? Like how much we burn. And that's a small part of how our body regulates weight. And so that's where our hyper focus went. But it's not necessarily that our metabolism has a major drop off. And there are some changes that happen over the life course. So for example, let's go back to focusing on women, right? That's our focus today. When we have that drop in estrogen that happens during menopause, we burn differently because where our fat's distributed is going to have us burn in a different pattern. So women often notice at that time that, gosh, I just don't feel like I'm burning in the same way that I may have burned before, I started going through menopause. And there's some truth to that. But the key issue with regards to like how much we're burning really has to do with our muscle mass. So what happens is as we age, we lose lean muscle mass. And what happens is when we lose that lean muscle mass, you can imagine that we're not able to burn as much with activity or even at rest. And so really around the age of 60 for both men and women is when we see that kind of plummeting of that lean muscle mass that gives us that energy to burn more. And this is why I encourage, individuals that haven't thought about maybe doing strength training, incorporating that into their regimen of the importance of it. It's not that you want to lift and be a bodybuilder, right? Like it would take a lot for a woman to morph their body into a woman bodybuilder's physique. That's not typically what our bodies will do. It requires usually a lot of external influences, substances that I don't necessarily recommend for that to happen. So what I do encourage is people to incorporate free weights and interval style training into their workouts, because that's going to help us keep some of the lean muscle mass. We're still going to lose it no matter how active you are. Even if you're someone that works out 6 to 7 days a week like I do, you're still going to lose some of that over time, but you're going to lose less than someone who's not engaged in that. And so that can be helpful in terms of protecting some of that decline and that burn, that metabolism piece that you brought up in your question.
That's great. So in other words,
Yeah.
we can't just lean on the fact that we're older and our metabolism is slower. That's why I can't lose weight.
Right. Well, it is. I mean, it's definitely much more challenging for both men and women. I would say for women, it's probably even more challenging, right? Because men don't have those major drops in different hormones like we experience even over the course of a monthly cycle when we are pre-menopausal, right? So we have just so many things that are going on in our bodies that men don't really have to navigate. But, it does become more challenging. And one thing I just want for people to know is that obesity, if that's something that you have, is not your fault. And part of the reason why I spent 3 years in fellowship really training to become this obesity medicine physician scientist is that I can provide care to my patients, even with more complex issues as to why they struggle with their weight. And that's where we're here. That's why we're here. There's obesity medicine physicians now, over 4,000 of us throughout the country that are here to provide care and to provide solutions to help you be your best self.
Perfect. And on that note, the time we air this interview, it's going to be the new year, new you concept, where everyone is going to be hitting the gyms. Everyone is going to be on some kind of diet. What advice do you have for women whose New Year resolutions are, I want to just, drop 30 pounds in the next 6 months, or this sort of new engaged enthusiasm for weight loss?
Yeah, I think that the enthusiasm is great, but I want to caution people about making these kind of absolute resolutions, like I need to lose 50 pounds or I need to lose 30 pounds. I'm going to do some type of really strict regimen that can't be sustained, because what ends up happening ultimately is that people are really great for at least, let's say, the first 2 weeks, maybe in the first month. So January is usually their spot on. Whatever it is they set in their mind they're going to do, they're able to do it. And then February creeps in March, April, and then we keep going down the course of the calendar year. And they find that, what they said in January seems a bit impossible to achieve. And when we set these goals that seem insurmountable, what ends up happening is we end up finding that we fail, or, for lack of a better way of saying it. And what that actually does to our body is actually worse. So when we weight cycle means that we do something pretty significant, let's say cut carbs or cut whatever it is, and we lose weight initially, the body remembers where your weight set point is. So your body is going to come back and it's going to surpass where you started, right? So that's why people tend to gain weight over time. And they're like wondering why, because they're like, well, I've done this diet and this diet and this diet. It's because the brain knows that what you're doing isn't sustainable. So I would caution people about picking goals that aren't sustainable for your rest of your life. So if you're picking something at the beginning of the year, think to yourself, is this something you want to do for the rest of your life? Let's say you're going to live for another 50 years. I'm just picking a number. Are you planning to do this for the next 50 years? If the answer to that question is no, then I want you to rethink and recalibrate what your choices are. I would pick something a little bit more attainable. Maybe, you know what, I'm going to introduce more vegetables into my diet, and I want to increase my vegetables by, twice. I'm going to eat twice as many vegetables in the first month or something like that. That's looking at the quality of food, something that's pretty sustainable. We can eat more vegetables. That doesn't seem like too insurmountable. That's a much better, approach to things. Or maybe, hey, I'm going to start off, I don't work out at all. I want to start off by working out 3 days a week. That instead of saying I'm going to work out every single day, unless you're someone that's been doing it like myself since I was basically born. I mean, you're not going to immediately jump into doing workouts almost every day of the week. It's just not something that's ingrained within your body as of yet. So set, kind of more bite-sized goals that are sustainable, because like I told you, if you go on something that's not sustainable, it will ultimately lead to a worsened outcome than where you already started. So that's I think the key advice I can give as we go into the new year of 2022.
Perfect.
Yeah.
And on that note, also, there's all, and I'm sure, as you know, there's tons of diets. There's, counting macros, there's the keto diet, the Atkins, all of these where there's probably elimination of some food group or a combination of food groups. For someone who's sort of looking to start on a clean slate, any specific advice as to a particular, maybe not diets per se, but, a particular style of eating that you recommend?
Yeah, actually, so I'm glad you asked that, because I don't ever recommend any diets. And you can ask any of my over 4,000 patients, have I ever put them on a diet? And they would tell you the answer is absolutely not. My goal is to get people into healthy eating that fits their lifestyle, their culture. And I would say that kind of the overarching theme that I would say is to make sure that people are getting in lean protein, whatever that looks like. If you're vegan, vegetarian, what that protein looks like, lean, obviously. Whole grains, fruits and vegetables. That's what I want the plate to look like. And I want, if you're thinking about a plate, whether it's a smaller salad size plate, which is what I typically eat off of, or a larger dinner plate, you want it to be, about 2/3 vegetables, half to 2/3 vegetables. That's where you want to take up most of your plate. And then you can fill in with other things. Notice I did not say to eliminate any particular food group. Our bodies do need, the different food groups. Now, the quality of the diet in those food groups matters. So when we talk about this elimination of carbs, which is a huge focus, right? Like carbs are evil, carbs are bad. That's not true. That's not true at all, actually. For some people, you put them on something like a ketogenic diet and they gain weight, right? So then what does that say? That obviously, for those people, that wasn't what the issue was. And for those that are remaining in ketosis, we don't really have a lot of great data on what that looks like long-term, except in the context of people that have refractory seizure disorders, which is where the ketogenic diet was developed and what it was based on. So I think the key thing is just making sure that you recognize that no one food group is bad, but the quality of things. So if you're eating really refined carbs, right, like cake and donuts, that's one thing, versus a whole grain toast or pita, that's another thing, right? So, or even, rice, or a brown rice or something like that. Those are very different, cake, pies, cookies, versus, a pita or something like this. And it's about, like I said, everything in moderation. It's not that you want to overpower in that category, but I've already told you that I want kind of half to 2/3 of that plate to be more vegetable predominant. What we've seen across all of the potential diet plans or even diet strategies and or looking at the quality is that vegetables are kind of the best source of energy, when we're looking at energy, which is our calories. So that's how I would say for someone that's starting out, not to get into this, like, I'm going to just eliminate all of these things and reintroduce these things. Let me tell you, I always see, even if you see weight loss initially, for most people, you'll see significant weight regain, and then you'll rebound to, worse than where you started. And then you'll be angry because you missed out on just eating more normal, right? Something that's sustainable over the life course.
Right.
Yeah.
And I love that you slipped in there that you eat on a salad plate instead of a dinner plate. That's a great little tip to people, right? Just a simple thing to start with.
Right. It's so easy, right? Most of us in our homes, we have our dinner, our big dinner size plates, and then we have our next size plates, which are salad plates. I mean, and you can really get small and get to those saucers where you just put your coffee cup, which might be a little tiny there. But
Right.
what I like about it is a lot of our brain and the way it works is we look at our plate and we decide, oh, it's full, right? So if you fill up a whole salad plate, you still see a full surface and you're like, oh, I'm eating a full meal. That meal may be reduced in size. It's still the same quality of the diet, right? That whole grains, lean protein, fruits, vegetables. But we're looking at it and you're like, oh, now let's say you wanted to go back for seconds and you had a smaller plate versus you had a big dinner plate and wanted to go back for seconds. Now you're probably getting to the dinner plate size, right? If you happen to go back for seconds, but if you go back for seconds in a whole dinner plate, we're eating two full dinners, right? So you can imagine that's it's just a little bit of a mind hack, for lack of better way of saying it. And it's just something that you look at it, you're like, wow, have all the stuff that I wanted, it's all here. And then you realize that as you're eating, particularly if you're eating not interrupted, which a lot of us do, including myself at times, where you're like watching television or something else where you're distracted and you're unable to listen to those cues in your body with regards to hunger and satiety. So hunger is how hungry you actually feel. Like, so you might say, oh, I haven't eaten breakfast, lunch, or dinner. Oh, I feel a little hungry. And then satiety, how long it takes you to feel full once you actually start eating. But when we're listening to our satiety cues, if we're doing like three things at the same time, we're on our phone, we're looking at the TV, we're talking to the kids, we're talking to our spouse or family, you can imagine that we're not listening to the cues that are telling us, you know what, I'm full. And this is often when we get to that point of feeling too full and get like maybe an abdominal pain or stomach, pain. And you're like, gosh, what? My stomach hurts now. I was hungry. Maybe I ate too much. Now my stomach hurts. But if you were listening probably to your food cues, you would have had a lesser likelihood of running into that situation.
And speaking of satiety, I know I've read somewhere before too that sometimes they say kind of measure it on a scale, when you kind of feel maybe a +4 or 5 versus, when you're 10 and your pants are tight and all of that. Is that sort of a good way? Because I think some people, as we grow older, I think we lose those cues, to kind of pay attention to that. We're so used to, oh, this is how much I eat. And that's, that's it.
Yeah, no, I think start listening to your body. And I don't give it like a number because some people get confused, like what scale are we on, or a 10-point scale, 5-point scale, so I try not to do that. But I just say, if you're eating like at a dinner table, like maybe with your family without like the TV and all of these things, like listen to your body and say like, oh, I'm still really hungry at this point. Okay, well, then that means that maybe you need to continue eating. And then once you start to first notice that, oh, I think I'm getting full, you might still have some food on your plate. And so maybe at that time you take a pause and you actually just, maybe talk to the family or do whatever you're doing. If you're at home by yourself, just kind of sit there, maybe you have a book that you're reading, and you just, wait. And then if you say that just for a few more minutes, you're like, oh, okay, well, I am really full. Then you would just stop eating whatever. You could pack that up, eat that tomorrow, for lunch or whatever. But if you are still like, oh, I think I still am a little bit hungry, then you can just push that past that. So that's how I would gauge looking at, that sense of fullness. And it's going to be different for each person. Now, some people have problems with their fullness cues. And that's often when I will, use medications, for example, to prescribe, to help change that signaling in the brain and the gut to change that sense of fullness. Because some people don't really have, they tell me, hey, look, I can eat 3 whole dinner plates and I never feel full. That's a reality for not an insignificant number of individuals. And so, like I said, we have to listen to our own cues. And if you're noticing that you're struggling, we as obesity medicine physicians are out there and we do have tools that can assist with that.
And it's so funny because you lead me right into my last question, which is, for patients that have tried everything conservative and they meet the obesity benchmark, what are some non-conservative surgical, if you will, and medication-wise options, and when should they consider it, and what might be some of those options?
Absolutely. So this is a great question. This is like what I live for, right? So, we always start with lifestyle and behavioral modifications, right? So that's looking at the quality of one's diet. Notice I haven't brought up calories, and I've been strategic in that way because I don't ever give my patients calorie counts. I don't believe in that. It's about the quality of one's diet, not the calories one's eating. I can give you 1,000 calories of jelly beans or 1,000 calories of kale, mushrooms, tomatoes, onions. And you can imagine that our bodies would process those differently. So a calorie is not a calorie is not a calorie. So we would look at diet quality without that focus on caloric consumption. In addition to that, we look at, in that lifestyle or behavioral realm, we look at things like physical activity. You want to get in at least 150 minutes of moderate intensity physical activity during a given week. That would mean that you would do 30 minutes, like 5 days a week. And during that activity, you should be able to talk if asked, something, but you wouldn't be able to sing. Like your labored breathing is such that you wouldn't be able to like carry a tune. That's what you think about in terms of moderate intensity. And then sleep quality and duration hugely plays a role in how our body regulates weight. And so if sleep is dysregulated, that would be something I would look at. I would look at medications that you might be prescribed. A lot of medications that we as doctors prescribe can cause significant weight shifts, particularly ones that are considered to be psychotropic drugs used to treat disorders like bipolar, schizophrenia, et cetera. Even medications to treat depression or blood pressure, things of this sort can cause major weight shifts. And I would look at all of these things first. So that'd be number one. For anyone that has any mental health issues that may complicate their process as we're looking at their weight regulation, I would bring in one of our psychologists. We have 4 full-time PhD level psychologists that treat patients with obesity. And so maybe they need more work in that area. And so that would be kind of under that lifestyle behavioral realm. For those that have done all of those things and still really have issues and or struggles with their weight, this is when we can begin to entertain pharmacotherapy or medications for obesity. And there are guidelines that we use. So if someone has, for example, a body mass index of 27, and they have obesity-related diseases like high blood pressure, sleep apnea, diabetes, for example, we could use medications in that situation. And then for anyone that has obesity, which by BMI criteria is greater than or equal to 30 BMI. Now, we can adjust or kind of go up and down around that because we know the BMI chart is not the end-all be-all for determining one's weight status. It's interesting to know that the BMI chart is actually not based on medicine. It's based upon life insurance data from the 1930s and 40s, where persons that were from racial and ethnic backgrounds actually were not included in the calculation. So I won't say that I would yield directly to what the chart says, but that's, the guidelines state. And then for those that have severe obesity, which would be anyone with a body mass index greater than or equal to 40, those people might be a good candidate for bariatric surgery. And the 2 most common forms of surgery performed in the US are the sleeve gastrectomy, which is by far the number 1 surgery. That's not just the number 1 in the United States, it's also everywhere in the world if you were to look throughout the entire globe. And then followed by that would be the Roux-en-Y gastric bypass. And a lot of people think that surgery is an extreme measure, and I really actually get a little bit frustrated when I hear that. It's about using the best tool for the size of the problem. And so when people have severe obesity, why not use the tool that's been shown to be best for that degree of problem, right? The severity of the disease. And it's one of the safest surgeries that we have available, here in the US and around the world. The mortality rate is 0.07%, right? That's like basically almost zero. And, when we're looking at the quality of life improvement, we see quality of life improvement in 95% of patients. Notice I didn't say 100%, but 95 I think is a pretty good number. That'd be a nice A in a class. And then we see a reduction in mortality of 89, improvement in mortality, 89% improvement in mortality over the course of 5 years. So that's huge. I mean, these are things that we cannot discount. And then, of course, a resolution of many diseases, like, and 88 to 92% of patients that have type 2 diabetes, they get rid of their diabetes usually within the first 5 days of surgery. I mean, that is unheard of with any medication regimen, right? We're treating the diabetes, and there are some great medications that we use for that, but to actually get rid of it altogether, I mean, we don't have anything that's of that. So I just want us to be aware, and I don't want us to be resistant to any of these levels of treatment, whether it's the lifestyle behavioral treatment, the medication treatment, the surgical treatment. And then one other thing I'd like to throw in there is that we have this device, and I'm doing air quotes on purpose. There's an agent that you can take that are gel. It's kind of like a gel. It looks like capsules, but it expands into a gel in the abdomen. And it's approved by the FDA as a device. Obviously, it's a capsule, so but it has no pharmacologic properties. And what it does is it creates space occupying gel in the abdomen so that when you go to eat, you're already kind of full, not completely full, but kind of full. And so you're like, oh, I'm not, I can only eat like maybe half of that salad plate. And so that's FDA approved, and a lot of great data out of that. If people are a little bit more hesitant to go down the medication pathway, that's a great potential start, or for those that are sensitive to medications for any reason. So that's kind of the range of therapies that we have available currently. Yeah.
Oh, that's perfect. That's perfect. Yeah. I know I definitely got some little tips out of this that I need to incorporate in, if not in 2022, before that. And I'm sure a lot of other people did too. Thank you so much. This has been extremely informative and really a fun conversation for me. I just want to also request our viewers to subscribe to our YouTube channel and hit the like icon. And also please visit our website at womenwhowin100.com. We're also on Facebook and on LinkedIn, as well as Instagram. Feel free to email us at womenwhowin100@gmail.com. Thank you so much, Dr. Stanford. Lovely conversation.
Absolutely. And also for all of you out there, feel free to follow me on all of my social media platforms at Ask Dr. Fatima. That's on LinkedIn, Instagram, and Twitter. I always am putting up fun tips for people. And so just kind of keep a lookout.
I can vouch for that. I follow you. Thank you.
Thank you.